quite polarizing. So, I mean, the reason that I personally care about resistance testing is that I have spent almost 10 years working in Botswana, and they have one of the highest HIV incidence rates and prevalence rates in the world. And back in 2012, we were performing a standard surveillance study on transmitted resistance, and the population we were using were young, pregnant women who were coming into the antenatal clinic. And back in 2012, we found that less than 1% of the women who were coming into the clinic actually had pre-treatment drug resistance. And that single individual, her name is Tassila, she was switched to second-line therapy because she had resistance to the first-line drugs that were given to her for PMTCT. And because of her resistance, they probably wouldn't have worked. And she was only genotyped for resistance because she was part of our research study, and because of that, her son Felix is HIV negative today. But it got us thinking, you know, there are plenty of women out there like Tassila who go to the antenatal clinic, find out that they're infected with HIV, and get first-line ART for PMTCT. But they don't get a resistance test. And then in 2014, 2015, we saw a huge jump in transmitted resistance in the same population in Botswana. And this year, it's almost 10% of women who are starting ART for PMTCT already have resistance to one or more of those drugs. So that was really the impetus for designing the technology that I'm going to talk about, which is PANDA. Now, this is a slightly old number, but I think we are still enabling access at a very similar rate. You know, this equates to almost one person every 20 seconds who's starting ART. But one of the biggest issues is that 80% of those people who have access to ART don't have access to drug resistance diagnostics. And there are really three compounding factors associated with not having access to resistance diagnostics. You know, the patient lives with unmanaged HIV for a very long time. There's a greater risk of them transmitting not just HIV, but drug-resistant HIV to others. And we saw from Dr. Cantor's talk there that transmitted drug resistance is on the rise. And healthcare resources are wasted on inefficient patient drug matching. So patients who don't have access to drug resistance testing are on the wrong regimen for an extended period of time. They're having to go back to their physician, get repeated viral load testing, and that takes up a lot of scarce resources. And we've known for almost 20 years that resistance testing can guide optimal treatment selection. This is from 1999, showing two different patients, one that received a genotypic resistance test and one that completely suppressed on their first regimen. So why 20 years later are we still trying to figure out how do we get those other 80% of people access to resistance diagnostics to give them complete optimal care? So why aren't we doing resistance testing? And one of the major factors is that the cost of implementing resistance testing at its current price point is equal to the amount of funds that are wasted on the drug-patient matching. So I know I can appreciate that ART is somewhat cheaper in India, but this is from MSF a couple of years ago showing the median first and second line costs. And resistance testing has a median of $300 per patient. So for $300, you could either give one patient a resistance test and put them on their optimal therapy, or you could supply two patients with first-line treatment for a year. So there really is no economic incentive at the moment to implement resistance testing in resource-limited countries. So how can we address this? Dr. Cantor spoke quite a bit yesterday about point mutation assays, and he linked into Bob Schaefer from Stanford, his work on what resistance mutations really matter during first-line failure. So if you can look at a Sanger sequencing, you get a lot of information, but really for first-line failure, there are only 6 resistance mutations that matter. And these 6 resistance mutations can allow us to really focus the genotyping, and that way design a much more optimal test for resistance. So with point mutation assays, even though they're much, much more sensitive than standard Sanger sequencing, they still haven't really got to a point where they've been implemented clinically. And some of you might be familiar with a very old technology that's still in use called real-time PCR or qPCR. You know, it's the foundation technology for viral load testing and a whole host of other genomic tests. So the way qPCR works is that you generally have a probe, and it will bind to its target. So this example here is perfectly bound. And what happens is there a complete match between your probe and your target, you get fluorescence, and you can detect that fluorescence. And if there's even a single mismatch between your target and your probe, the probe won't bind, there's no fluorescence, and therefore you get a negative result. So in resistance testing, it would look something like this. You measure the amount of fluorescence over time, and in a positive sample, you get high fluorescence, and in a negative sample, you get the same as the baseline. So that's the basic premise of qPCR. So why have we never implemented it for HIV drug resistance testing? And the problem is that, HIV is a moving target for sensitive diagnostics like qPCR. In a single individual, it's always changing, mutating, and that's the primary reason why we've never been able to implement qPCR in such a manner. So here I've taken a very well-known drug resistance mutation for the K103M mutation for the verapamifavrins and NRTIs. And that resistance mutation is coded by an AAC. So in the perfect scenario, you have a probe that matches your AAC drug resistance, you detect the fluorescence, and you say, yep, resistance is present. But in the real world, HIV is constantly changing. So even if your drug resistance mutation is present, there are going to be other mutations not associated with resistance, but natural polymorphisms around that AAC, so your probe won't bind. And this results in a whole host of problems. We have 30% of patients would end up with a false negative result, which isn't acceptable for any sort of clinical diagnostic. And if you look at the 103, the region around this 103 mutation here, you can see there's a whole host of mutations that would really prevent the probe from binding. So as I said, those 30% of patients, even if they had resistance, an assay would say no. So pan-degenerate amplification and adaptation, or PANDA for short, is a way to circumvent that problem of these additional mismatches, these additional natural polymorphisms present in the HIV genome. And I'm not going to go into too much of the technical detail because I appreciate that a lot of you are clinicians and are more interested in the implementation, but what PANDA does is it strips out all of those additional mutations that I just showed you. So what it will do is it will actually mutate the HIV genome so that it matches your probe. And the net result is that even if you started with a patient sample that had lots of mutations, you end up with a patient sample that's going to match your probe. So to put it in the context of all the sequences I just showed you here with all of these different mutations, those 30% of patients through 2 through to 11, what happens is that PANDA just gets rid of those additional mutations. So those 30% of patients that would have been a false negative can now successfully be genotyped by PANDA. So how do we implement PANDA as a clinical diagnostic? It did start off as a research tool. It was developed when I was at the Harvard School of Public Health, and it's now morphed into a startup company called Aldatu so that we can provide PANDA to first and second line treatment failures. So PANDA is a kit. It plugs into existing real-time PCR machines that are usually ubiquitous in centralized testing laboratories. And what PANDA can do, it can look for those 6 resistance mutations I said at the beginning that can be found in over 99% of patients failing first line with resistance. It acts as a confirmatory viral load, and I'll explain more about that in a moment. And it can detect resistance when it's present at 1% or more of the virus population. In terms of the implementing it, we can genotype 24 patients in 2 hours. It's very affordable. We've designed it to be thermostable, and it's completely subtype independent. So some commercial Sanger sequencing kits, such as VirusSeq, have had issues with non-B subtypes and failure to genotype there. So PANDA has been specifically designed to be subtype independent. So it's one kit that can be used anywhere in the world. And one of the issues we've also tried to address is how can we make it as user-friendly as possible? If anyone in the audience has ever done Sanger sequencing for resistance testing, or even just sent a sample for resistance testing, you know that the turnaround time is quite long. The workflow for Sanger sequencing is between 2 and 3 days to get your results. So we really wanted to get to a point where we had a sample-in, answer-out approach to resistance testing. So this is the workflow I was talking about. This is Sanger sequencing at the top and Panda down the bottom. So there's a over 95% reduction in labor time. So the cost saved not just in buying the kit itself, but actually implemented it in terms of labor and overheads is greatly reduced. So one of the biggest barriers to cost-effective drug resistance diagnostics is the need for the cold chain. So shipping the reagents on ice, storing them in a fridge, so on and so forth. So it comes with enzymes, buffers, primers, probes, and most of these have to be stored and shipped at -20. And that was one of the first barriers that we wanted to overcome when translating Panda from the lab-based test into the clinical diagnostic. And what we've done is we've worked with a couple of manufacturers in lyophilization and thermal stabilization, and we've turned Panda into this. Hopefully you can see it, but at the bottom of the tube there's a very, very small pellet. And in that pellet, it contains all the enzymes, buffers, primers, and probes needed to do a viral load and detect 2 resistance mutations. So one patient would have 3 different types of those, we call them lyospheres. And that's completely thermostable, so it can be shipped at ambient temperature, stored at ambient temperature, and then just taken off the shelf when you need to use it. And this is the sample in answer out point. So this is a 96-well plate with a lyosphere at the bottom, and it would be just a matter of pipetting in the patient sample. So once you purify the viral RNA from the patient plasma, you just add it to 3 different wells, which covers 6 different resistance mutations, and then you place it into your PCR machine. So that's second step there. So once the 2 hours is completed, because it's a quantitative assay, you can actually get an automated viral load and resistance report. So Sanger sequencing at the moment requires a technician to go through the sequence, check for sequencing errors, make sure that the sequence that is reported matches up with the data. But with Panda, because it's quantitative, there's an automatic translation, and there's no need for the end user to have to do any interpretation. So how does it perform? So if you remember the qPCR slide I showed earlier with the fluorescence versus time, in Panda, I said we detect a viral load. We call it a viral quantifier, and we use that not just as a control to make sure that there's HIV RNA present, but also as a way to do the quantification of drug resistance. So for those of you not familiar with real-time PCR, what you do is you look for a particular level of fluorescence, and then ask, how long does it take to get to that level of fluorescence? So the higher the viral load, the earlier a particular fluorescent signal will appear. And here I'm showing you a 4-log range from 100,000 copies down to 100 copies. And you can see that as you have less HIV RNA, it takes longer for the reaction to get there. So how do we translate that into drug resistance detection? So here we have an example, 10,000 copies of viral RNA. Same principle. And what we see is the resistance signal comes up at the same time as the viral load, the viral quantifier. If we can say, okay, this virus has 100% K103 and 100% M184 V or I. Now, we don't differentiate between the V and the I at the 184 position, because clinically, there's no real relevance in knowing which it is. So by reducing it to both, then we can save time and space. Here's another example. We're putting in 1,000 copies, and here I'm showing that we can actually detect resistance at 10%, so 100 copies of RNA. And then a couple more examples. This is one where we've mixed it up. So this particular patient sample has 100% K103N, but only 10% of the 184. And then on the flip side, we have 1,000 copies, or 100% of the 184 resistance mutation, and 10% of the K103M. So when would this become available? So we're a very, very small company. We're a startup formed out of Harvard. There's only 5 of us. And we're all scientists by training, but thankfully we're very generously funded by the NIH. And we focus a lot on NIH funding because it allows us to keep our costs as low as possible. So we're in a phase now where we are piloting Panda, hopefully moving into Botswana and Tanzania in the next few months to see how it really performs with the end user. And then by this time next year, scaling up and hopefully getting it to clinics. So the first iteration that we're working on, as I said, is for first-line failures. But we recently just got funding from the NIH to translate Panda into a clinical diagnostic for second-line failures. So that would look for 2 NRTI mutations at the 65 and the 184 position, and then 5 protease resistance mutations as well. The biggest question about Panda is probably, that should actually have the symbol for rupees, but I guess that's failed. The question is, how much is it going to cost? And the answer is I don't know, because what we are trying to do is keep the cost as low as possible, but make it cost-saving or cost-efficient for a particular national program or country to implement. So to explain that a little bit better, a lot of work has been done in South Africa trying to determine if resistance testing could ever be cost-effective. South Africa has one of the highest absolute number of patients, both on ART and with HIV. And they've shown that if a resistance test was under $100, it would be cost-saving to the national program to implement. And the reason for that is, and to go back to Dr. Cantor's talk, he showed the prevalence of resistance at first-line failure in India, and it ranged from upwards of just under 60% all the way up to 90%. But between 10 and 40% of those patients that didn't have resistance, they would be switched to second-line treatment without a resistance test. But they have adherence problems. So some of the biggest cost-saving benefits from a first-line resistance test isn't actually identifying those with resistance, it's identifying those without. And I think the average or the median is around about 30% of patients are currently switching to second line, which is much more expensive, 3 or 4 times the cost, when they have adherence problems and no resistance whatsoever. So that was what was shown in South Africa. If you could prevent 30% of people from switching to more expensive second line therapy, you would save South Africa $125 million over the space of 5 years. So that's about 10% of their HIV budget, and that would put over an extra 500,000 people on treatment for a year. And more recently, they've shown in Brazil as well that if you do pre-treatment resistance testing, because transmitted drug resistance is on the rise, the more people that have access to treatment, the more transmitted resistance is going to increase. If you implement a pre-treatment resistance test before first line, it would actually save a country like Brazil $10 million a year. So they're paying for a resistance test, and it's saving them $10 million, which isn't something that happens very often in diagnostics. So I'm going to leave you with a question. And I've learned a lot while I've been in India over the last few days about how the treatment system works, and that it's really the patient here that's paying for their own care. So if it is the patient that's paying for their treatment monitoring, how do we prioritize diagnostics? If we were to introduce resistance testing, is there something that has to give? Would CD4 monitoring still be necessary? At what point can we fit in resistance diagnostics to make sure that these patients are on the right therapy at the right time? So I'd just like to end by thanking the organizers for the invitation to speak, particularly Dr. Jalada. And as I said, a lot of this work was done at the Harvard School of Public Health, where I had an absolutely phenomenal postdoc, some of you might know, Tripti Galada. And as I said, Aldatu Biosciences is a small team. There's just 5 of us, but we hope to grow in the future. So thank you for your attention.